Today. Again, my name is Tony Percelli, and I'm an assistant dean in Hofstra University's School of Health Professions and Human Services. Welcome to the State of Hope. State of Hope stands for Healthcare Opportunities and Policy Exchange. Today's topic is aging in America. For the past several months, I have been working very closely with Senator Kemp Hannon for today's event, and we're delighted to have you all here today to hear from our expert speakers up on the stage. Before we begin, just wanted to point out again, once more, in the back of the room, we have light refreshments. Feel free at any time to help yourself. If you would like, at any point, just go right on back and grab something to drink. While we are speaking, or while the presenters have finished speaking, there'll be an opportunity for audience engagement, at which point we'll call upon you to ask questions or make comments, okay? At this time, it's my pleasure to introduce to you our Dean of the School of Health Professions and Human Services, Dr. Holly Syrup. Dr. Syrup has been at Hofstra University for over 35 years and has held a number of positions, including Dean of Students, Vice President for Campus Life. She is also a full professor in the Department of Counseling and Mental Health Professions. Later became Vice Dean for the School of Health Professions and Human Services, and most recently our Dean. Our school has seen rapid growth and expansion under her tenure, and it is my absolute pleasure to ask her to come on over to the microphone and give some welcoming remarks.
Thank you, Tony, and thank you for all the work that you've done with Kemp to really coordinate this wonderful event this morning. We really appreciate it. And thank you for giving me that warm introduction. I've been here for quite some time. I say I've been here since the first tulip, and you can understand why this topic is particularly of interest to me, aging in America, or aging at Hofstra, from my perspective. I literally grew up here, which has been a wonderful experience. Thank you for joining us. Any of you, just show of hands, attend our last State of Hope? Yeah, so we've got some repeats. That's wonderful. We want to see that. This is a series that we decided to investigate when Kemp joined us, and I'll talk a little bit about that, to really bring people together to the university, to make it a spot for convening, to talk about important topics which are impacting us as we go forward. And aging in America is certainly an important topic. And why? Actually, I do have some statistics. The number of New Yorkers aged 65 and over has increased 26% since 2007 to 2017. That's huge, and that's just in New York. But I think the most important thing is that this population is on a real continuum. So on one hand, we see people who are living longer, who are working longer, who are going into second careers, who are looking for lifelong engagement and learning. They're not just stopping and stopping out. They're very involved. And yet, on the other hand, we do know that poverty rates for this group have increased, and that there is a number of eligible people who are on wait list for services and have increase in health needs. So these are all the various people in this one group, this aging group in America. And all of us, whether we're students, I know we have some students here, and we have community members, are all aging. And so it's important that we start to talk about this now and continue to talk about this in the future. We know that our health systems are really at a time of transition and change. We'll be focusing in on that, but also just the experiences of everyone who is in this part of their life. It's important for us to continue to talk. One of the goals of this series, as well as our School of Health Professions and Human Services, is to bring people together to talk about important topics. And in fact, that's really the goal of the university, bringing people, students, faculty together to talk about to share ideas, to begin to develop advocacy plans so that we can help people going forward. I would really like to thank our panelists. I'm not going to go through their bios. You do have their bios, and I know that Kemp is going to be introducing them each individually, but you are really in for wonderful conversation. And it's not just that they're going to be speaking at you. They really want your feedback, and we really want this to be interactive so that we really walk out of here in just a few hours with not only some great ideas, again, some ways that we can really all help in some way. And so this is a working session for all of us in the room. And so we appreciate you being here, and we ask for your participation. So thank you, panelists. You're wonderful. And I'm going to turn this over to Kemp. Many of you know Kemp Hannon after a very distinguished career in the Senate, where he is known for reaching across aisles, which is such a pleasure to see in today's world. He joined Hofstra at the School of Health Professions and Human Services as our Health Policy Fellow. And he has been working with us to develop programs, to reach out, to really make us a place where people come together to discuss health policy and to look for different types of futures for all of us. So thank you, Kemp, and I will turn it over to you.
Thank you. Good morning. Thanks for joining with us. It's going to be, you're going to have a little bit of imagination, because I wanted to get a room that would have a round table. And so the panelists could be looking at each other, and then they could interact as opposed to giving speeches to you. And then after some interaction, then we could take some questions. So this is what we got. And I didn't realize why we got this until I got this week the Hofstra list of events for the spring. And it's absolutely incredible, the amount of intellectual activity that's going on this campus this month and the next couple of months until the semester is over. And I was also then delighted to find out that this event was in that list. So it's something that if you have access to or look on the website, it's a pleasure to be here. And it's a pleasure to be here to deal with the health arena in a way that I didn't have a chance to do that before in the legislature. There it was a lot more top level, it was a lot more not involved in the details, and you're accepting what came your way. Here we have a chance as in academia of being able to do a little bit of shaping what's happening, raising topics that are not necessarily of the moment. If you're at all involved in healthcare in the state right now, you are spellbound by what is happening and not happening with the state's budget and the amount of cuts that the governor has proposed, $2.5 billion that would go into or come out of the healthcare arena. Won't go into that too long, especially because I'm barred from doing anything with the legislature for another year. And given the circumstances, that's a welcome bar. The order of speakers: Professor Carrasco, Dr. Lieberman, Stuart Ulmer, Marianne Grady, and what we're trying to do is just speak for a little bit of time, have a little bit of interaction, and then go to questions. So first off, and this is very difficult to tell a professor this, but she wanted to do a PowerPoint. And I said, I'm not so happy about PowerPoints, because people tend to just look at the PowerPoint and not think about what's being said. I would like to have people think about what's being said. And Professor Carrasco is a really good person to raise all of the different questions in regard to health. Major background. You'll be astounded when you look in your program and read all the things she's done. I'm going to bring her on right now to kick us off. Professor?
Thank you. So good morning, everyone. Thanks. And thank you to Senator Hannon and Dean Syrup and Assistant Dean Tony Porcelli for putting together this series and inviting me to be on the panel. Really excited to hear from and interact with my colleagues up here. I want to start off by saying what I'm going to talk about is all of the positive aspects of an aging population. You will read and hear about silver tsunamis. You'll hear about the graying of the population, the burdens, the stress on the healthcare system. And while those are complex issues, and we need to think about that, I would like to look at the aging of the population through a positive lens and talk about the opportunities that it presents, because it is a tremendous, positive public health success story that we have the numbers of folks who are living into very old age, and that the numbers of folks over 65 have expanded so exponentially. New advances in medicine and living standards have enabled us to reach these milestones. And yes, they'll have implications for social, economic, and health sectors, and we do need to consider that. But it's still lots of opportunities present. Why are there opportunities? Because the generation that we're seeing now that's turning 65, the baby boomers, they're more productive and living longer, productive, healthy lives than any previous generation before that. We also see rapid innovation across sectors, which is really quite exciting to see what's happening, how we're redefining what it means to be old, how we're reimagining what healthcare for older adults looks like, and how we're reinventing the workplace and retirement and what communities look like and how they can function. So I want to spend a little bit of time, as per Senator Hannon, to talk about the innovations at the community level that I've had some interaction with. And then I want to talk a little bit about areas that I'm hoping to get into in the future, and then some areas that I think we need some policy action, is how I'll kind of wrap up. So first I want to talk for a bit about integrated care. I first came into the field of aging in the mid-90s as the director of research at Metropolitan Jewish Health System in Bay Ridge, Brooklyn. And I was there for several years. And while I was there at this large continuum of care provider that has nursing homes, skilled rehab, home health, palliative care, hospice, they also had, at the time, a social health maintenance organization, a social HMO, which unfortunately was sometimes also called a SHMO. But it was a social HMO. And this social HMO back then was intended to test how best we can integrate healthcare with community-based long-term care services. So that should sound familiar to all of you, because those of you who are working in healthcare now know that we spend a lot of time, still 25 years later, trying to figure out how best to integrate community-based services with healthcare services. Why? Because not only for older chronically ill adults, but for all individuals. That's how we fulfill the whole picture. That's how we get to better healthcare outcomes. That's how we get to improved quality of life. In fact, we can't get to good health by just looking at one side of the puzzle. We can't just look at healthcare alone, and we can't just work in a silo in social services or in the community. We need to bring these two sectors together to have a comprehensive picture of what produces health. So this was my first introduction, really, in an applied setting to the social determinants of health and the power that the social determinants of health have. And I was fascinated. I went on to work with the United Hospital Fund of New York City, looking at how can we improve naturally occurring retirement communities. So some of you may know that, otherwise known as NORCs, another interesting abbreviation. NORCs are neighborhoods that were not specially designed for older adults. There was no intended planning. It's just that there are now more than half of the residents in that particular community are over 60. So what happened? Folks moved into a community, perhaps raised their family, and then they stayed. And now they're aging in place. And the United Hospital Fund in the early 90s was looking to see, how do we identify these neighborhoods that are aging and have more than half of their residents over 60? And so they helped to kind of define this term, this naturally occurring retirement community. And they said, how do we help people age successfully in place? And so one of the things I worked on with them is figuring out how to develop social service programs that you could bring into the community to enable people to live independently, to maintain their independence in the community. And my specific involvement in that project was to see how best to link NORC social service programs with healthcare entities. Because once again, it's great to have a social service sector within a community that's aging, but if individuals there have a fragmented experience with the social service sector and the healthcare sector, you're not getting at good outcomes. So we tested several different models of integrating healthcare entities with social service programs. And to this day, we're still trying to kind of work out the kinks and figure that out. There are some really good examples. We're continuing to do that. You've seen through DISRIP, the delivery system reform incentive payment, where we're trying to find ways to help hospitals and community-based organizations work together. Accountable care organizations that are trying to kind of bring in-house all of the different entities so that we have a more comprehensive picture. Health homes. There are lots of kind of new iterations of these older social HMOs, which ultimately went on to become a Medicare Advantage program. And you've heard of PACE, the Program for All-Inclusive Care of the Elderly. We've been testing out these models for a long time. The reason why I wanted to bring it up, it was kind of my first introduction to the importance of that integrated care and the fact that I think it's key, really key, to continue allowing healthcare and the models to evolve such that we're working in partnership with the critical community care partners and entities that fulfill that other picture and address the social determinants of health. I next want to talk about a related issue, which is age-friendly communities, and we'll hear a little bit more about that with one of the other speakers in a few minutes. While naturally occurring retirement community social service programs and their health partners can really help individuals who are living in communities with chronic illness or other frailties maintain their independence, older adults should have the opportunity to connect with their communities beyond their care needs. And so the American Association for Retired Persons started with the World Health Organization in the mid-2000s an age-friendly network initiative where they said to cities, counties, states, you can apply to start moving your neighborhoods, your communities towards a more age-friendly status. And there's a whole bunch of criteria that's required. You have to think about the physical, the built environment. You need to think about how sectors work together. You need to think about transportation. Think about the challenges that older adults may face, particularly in the suburbs, but in lots of other places as well. What if they're no longer driving? What if they don't have family nearby? All the kinds of challenges. And those are the things that maybe are outside of the healthcare system, but they're going to make or break whether or not individuals can live successfully, productively, independently in a community. So as of this month, there are 6 states that are moving towards age-friendly status and have an AARP designation, and New York is one, which is exciting. There's 1 territory and 442 communities nationwide, and a bunch of them are right here on Long Island, which is really exciting. So the city of Glen Cove, North Hempstead, Great Neck Plaza, and Brookhaven, in addition to both Nassau and Suffolk counties, are moving and have committed to improving the development of their communities to become a productive community across all ages, across the age span. And it also means that elected leadership has committed to putting resources towards this, to integrating across sectors and settings. So I think that is tremendously positive. And we're also seeing other sectors move towards age-friendly status, or they want to move in that particular direction. Age-friendly health systems, and we'll hear Dr. Lieberman talk about that in a few minutes. Age-friendly workplaces and age-friendly universities, which I'll come back to in just a few minutes. I want to turn just for a second to another interesting innovation that's somewhat related, and that's time banking. I'm not sure if anybody's heard of this particular concept, but I'm working with the city of Glen Cove through their age-friendly initiative to develop a time bank in Glen Cove. And a time bank is a program where people exchange services for time-based credit, not money. It's a different kind of currency. We call it a community currency. We're actually trying to connect people to each other to help provide needed services. The difference, not only that there's no money, but the difference between time banks and traditional volunteer programs is that a traditional volunteer exchange is usually one-directional. I'm providing services to you because you need services. Whereas in time banks, every member must be both a provider and a receiver of services. It's this reciprocal relationship that demonstrates that everybody has value. Everybody has something that they can offer that someone else may need. And 1 hour of service is equal to one-time credit regardless of the service you provide, whether you're helping someone change a light bulb, reading the newspaper to them, teaching them a new language, babysitting, providing respite, taking them grocery shopping, or providing a warm meal. So the key point is that everybody has something to give, and everyone has value. It's about neighbors helping neighbors, and we know that there is an increasing large body of research that shows that social isolation and being disconnected in your communities is going to have very negative impact on your physical, mental, and cognitive well-being. And yet, today, more so than ever before, there are more people, young and old, that do not have someone they could call to help them change a light bulb, or because they may need a conversation to connect with someone. And this is for lots of different reasons, whether it has to do with geographic dispersity, whether it has to do with rising levels of divorce or fewer children. There are lots of different reasons that go into this, but people are less and less connected. And Time Banks is an initiative that offers an opportunity to maybe connect people based on where they live in their community. There are about 120 time banks, you might be surprised to know, just in the United States, and many more, at least double that around the world. And I'm really looking forward to rolling out the Glen Cove Time Bank, and I hope that perhaps some of you will participate. Okay, 2 other quick areas that I want to mention that I would like to start getting involved in. One is we are starting to see the industry rethink retirement. In fact, it's been said that the baby boomer generation is retiring retirement. More and more older adults who are living healthier, more productive, longer lives are remaining in the workplace, partially for the financial support it provides, but partially also for the ongoing stimulation. And that arbitrary number of retiring at 65 is really antiquated. And we have to start thinking a little bit differently about retirement for lots of different reasons. Fortunately, most older adults want to be somewhat involved still in that, either through civically, voluntarily, volunteering, or working in some capacity. And we find people over 65 taking on leadership roles, starting new businesses, and getting really engaged. So what I would like to see is how can we encourage through, it could be public policy, tax incentives, tax credits, or other kind of mechanisms, encourage employers and employees to think about extended kinds of workplace relationships. Now, older adults tend not to want the traditional kinds of work behavior. They're looking for flexible work arrangements, part-time responsibilities, more entrepreneurial kinds of opportunities, and the growing digital economy is really transforming this later life experience. Another thing that's really interesting is how we could rethink higher education, and it's kind of tied to rethinking retirement. There are a lot of really interesting educational experiments happening right now in universities: Harvard, Stanford, Pace, Wagner, University of Connecticut, Arizona State, just to name a few. These are among the 75 universities that have committed to moving towards an age-friendly university. And that means thinking a little differently about who is their student. I see this as a quadruple win. Number one, it helps older adults prepare for second, third, or as we're sometimes calling encore careers through informal or formal training programs. 2, it helps the workforce reap the benefits of experienced and wise employees. There's lots of data to show that older workers are more loyal. They're better collaborators. They're better team members. They're more effective problem solvers. They're excellent mentors. They have institutional memory, wiser. They're good problem solvers. So we need that expertise in-house. So it helps the older adult, it helps the workforce, it helps higher ed, which has to reinvent itself because it's transforming right now as we speak. And this is another population to think about. And it helps society in terms of productivity and reduced pressure on public programs. So I'm looking forward to seeing whether or not we can consider Hofstra on track to become one of the next age-friendly universities. And then I will conclude with just a couple of areas that I think we really need to see some policy action. And the first and probably most important is likely the most difficult, and that is we need to see greater investment in reducing current gaps in education, employment, and earnings among younger workers. And that might be somewhat surprising to hear me say that, but there's a lot of research that shows that the health and mortality differences in older adulthood are closely related to the socioeconomic conditions and work experiences for younger adults. So you know what? This isn't about putting resources in one particular age demographic versus another. It's about thinking about this as a lifespan approach. I think we have to strengthen laws against age discrimination. I think we have to provide incentives, like I mentioned before, to encourage older adults to stay in the workforce and employers to think differently about what that working environment or relationship should look like. I think we should be finding places where we can seed money for older entrepreneurs, and I'm really happy that Bank of America Merrill Lynch is starting to work with the Stanford Center on Aging to look at some of those kinds of new initiatives. So it's starting. You see the market moving in that direction. We need to create incentives for developers and others to invest in buildings and landscapes and urban plans to make it easier to age in place. And we have to support programs like time banking that can foster community connections and fill the gaps that is left by limited insurance, the lack of resources, and very few caregivers. I'd like to see investment in technologies to improve older adult engagement, productivity, quality of life, and to reduce the need for expensive long-term care. And lastly, I'd like to see more support for public health campaigns where we can raise awareness and start to reframe the discussion about what it means to be old. And to this end, I'll put my students on the spot. I'm really proud to be working with my Master of Public Health students in the population aging class I'm teaching this semester on the second annual Aging Cafe that is going to be held on Tuesday, April 7th here on campus as part of National Public Health Week, where the students are going to help attendees rethink, reframe, reinvent what they think older age means. Also, our School of Health Professions and Human Services is working to build a more age-friendly workforce through its new Advanced Certificate in Healthy Aging, which is just now being launched, and a new Master's Program in Healthy Aging, which is soon to come. So in conclusion, despite all the scary talk and some of the gloom and doom, I'm particularly excited to be working towards a future that advances public health, creates age-friendly homes and communities, enables lifelong learning and work and entrepreneurship, and promotes purposeful aging engagement and volunteerism, and I hope you will all join me. Thank you.
Wow. No ivory tower for this professor. But a great overview and where we're going and what we need to do. Next, we'll have Dr. Tara Liebman, who is not only leading Northwell in its geriatric initiatives, but is a practicing physician for palliative care and geriatrics and all the complications that go in when somebody is ill and aging. Recently spearheaded for Northwell the introduction of geriatric care in each of its emergency rooms, each of its 23 hospitals. So that's a pretty difficult thing to do. And Dr. Liebman, I'd like you to kind of give us an overview of how you did it and what your challenges are.
Thank you so much. Thank you all for having me here. So I want to just follow a little bit of what we've been hearing, some terms over and over again. One, the silver tsunami. Everyone is speaking about that. Nobody likes it. People have been actually yelled at on Twitter for calling us that. But the reality of it is, for the first time we've ever had, the older population is going to be a larger population than our younger population. And so how are we prepared as a community to care for patients who are older and living longer and living healthier? So that's one term that I've been hearing quite a bit. And then the second term is the age-friendly community, age-friendly health system. And so what I'm going to focus on today is on the age-friendly health system and how healthcare is preparing for this silver tsunami. So I'm an internist, geriatrician, palliative care trained physician by background. I would like to say there are lots and lots and lots of me, but unfortunately there are not. It is not a sexy job. It doesn't pay a lot of money. So unfortunately, our profession is actually stagnant and if not sort of dying, which is actually counterintuitive to the idea that our health system is getting older and we have less and less geriatricians, less and less palliative care physicians out there. And so we recognize that, and we're doing our best to recruit, but we've also understood that we can't just be the only ones to care for this patient population. We have to be influencers, and we have to influence other healthcare providers on how to care for an aging population. And so we have been working with large organizations like AGS and the Hartford Foundation on how to make our healthcare an age-friendly health system. What does that mean? Right? How is it any different than caring for any other patient that walks into the doors? Well, there are some really important things that we really have been sort of taken for granted in the past and now have to think actually specifically on how to care for an aging population. And we look around the 4 M's. So what are the 4 M's, right? The first is mobility, right? And I'll talk a little bit today about mobility and how that affects our healthcare and our healthcare providers. Second is mind. We have a growing aging population that is actually living with dementia and their caregivers around dementia. The third is medication. And medication becomes quite complicated as one ages because we have more and more comorbidities and they're taking more medications. And are they always necessary? And how do they interact with each other? And how is it affecting an older adult? And then the last is what matters most. How do we tell our providers what we need and what we need at the right place at the right time? So I'll first start with mobility. So we live in Long Island, and I think you all know, Levittown was the first suburb of the country. And we built these beautiful homes, and we all moved out, and we lived in beautiful homes. But we did not put ourselves near public transportation. We did not think about the fact that we couldn't walk up and down stairs. We did not think about how we are going to get to our hospitals and our physicians because we live nowhere near them. And so we are seeing communities like Glen Cove who are isolated from public transportation. We're isolating ourselves from major health institutes. We're isolating ourselves from healthcare providers. And so as a health system, we are recognizing this, that mobility is really important, and how do we get patients transportation? How do we get patients to live friendly in their home? Meaning, how is it safe for them to remain in their home? How are they able to move from place to place? And so we are mindful of that when we see a patient. And so I do that as a geriatrician, I do that as a palliative care physician, but I don't think my colleagues in cardiology recognize that, right? They say, please come in 2 weeks and forget about all the complications that go around it. So our goal for the next year is to really talk about these 4 M's, and M mobility being one of them, and how we can integrate maybe telehealth, how we can integrate home care services, how we can integrate different care in an Uber system or a Lyft, whatever, in order to get sharing of population, and then actually moving some of our healthcare providers to communities that are at need, like Glen Cove and the Suffolk County, where people are aging in place so that they can have less traffic coming into our more congested areas. That's number 1. Number 2 is mind. So we are an older population that is brighter and brighter and brighter using technology. But unfortunately, we're also seeing an epidemic of dementia. And not only is it an epidemic of dementia, but it's an epidemic of dementia and their caregivers. And how do we handle that with all the medical issues around memory loss? Some patients are, in the early stages, and not even noticed by their care provider, correct? So they go to their doctor, they say hello to them, or their nurse practitioner, they say hello, and they do their regular assessment, think that everything has gone well, and then they move on. They have never remembered anything that just happened. And so we are trying to be influencers of our colleagues and understanding how do we assess for memory deficit? How do we look for the caregiver who is dealing with memory deficit? We talked a little bit about people living independently, right? This is this phenomenon that people are aging alone. Their loved ones have either passed away or they've moved to California. And so we kind of think of them, as my colleague would say, an eldered orphan. And so they are not getting the support that they need when they go to their provider. And so they are not recognizing the cognitive impairment that they may be having in their community. And so being a part of healthcare, that is one of the things that we're looking at. The third thing is medications. And I'm sure if you see the average older adult, they have about 9 medications. And that doesn't include the over-the-counter medications. And so they've just been continued on forever where they've seen. They went from one doctor to the next doctor, to the hospital, to the rehab center, to home, and it just continues on, and nobody actually reconciled it and realized that these medications should not be given to this patient at 90 when it was the same medications when they were getting it at 60. Their bodies have changed, their medical conditions changed, their support of actually taking these medications has changed. And so we have to be influencers of our colleagues of how do we have them assess medications. I can't do it by myself. There's lots and lots of adults out there who need the support. And then lastly is what matters most. And this is always a question of, I've been through this healthcare world and I've seen all these doctors, but I don't know if I can continue to go back to each of these doctors. I don't know if I want that procedure. I'm not sure I want to be living in my home anymore. I don't feel safe. So what matters most? And that means, do we make sure we designate a healthcare proxy, somebody who could be their voice when they need support. Either they can't speak for themselves or they need support in what they're talking about in a larger concept. And so this has been a push for us to be able to influence people to ask questions that are meaningful to a patient and their loved ones about how to care somebody in this growing healthcare field. So the touch point of what we sort of started this in our health system is the Geriatric Emergency Department accreditation. And so we realized we can't do it. We want to find others who can. And where is the first touch point with a lot of geriatric patients or older adults is in our emergency room. And only in just in the last few years has the American College of Emergency Physicians recognized that the population is should be looked at differently, and they made this accreditation. And we had challenged ourselves to say, this is going to be our first touch point. Who can we influence? And so the team was so excited to say, you know what, this is really important to us too. We are seeing these patients. We don't know how to care for these patients, and we want to know. So we partner together to allow them to understand how to recognize an older adult, how to recognize delirium, how to understand what matters most to the patient, asking about healthcare proxy, asking about discussions about end of life. And we were able to accredit all of our emergency room at the lowest level, which is level 3, with our goal to increase the higher levels in specific places across our touch points that have a larger aging population, like Glen Cove, and up in Westchester, like Phelps. So we are very mindful of what healthcare is to come, and we hope that with our age-friendly health system, we can influence others around us. So I will leave you all.
Thank you, Doctor. I wonder how difficult it was, because what you introduced was not what a hospital system usually does when they say, well, we want to improve our coronary, we want to improve our cancer, and we will hire a specialist. What you did is you actually changed the delivery system, and which is kind of what we need to do in not only just in healthcare, but as what the professor was talking about, changing society's delivery system for the aging. So it's an interesting parallel there.
Yeah.
Stuart, you day to day are a provider of health care for the elderly. You have the Gerwin healthcare system, the nursing and rehab center, you have residences, you have a home care agency, and you probably have any other variation of acronyms that the state has invented that's in the middle of it. We'll get to MLTCs, which are all important with Ms. O'Grady, but just tell us a little bit about the challenges you face and the delivery, and then what you see in the next 10, 20 years.
Right. Thank you, Senator. So I'd first like to welcome everyone and thank you all very much for having me here, especially the Hofstra leadership. I did have the opportunity to teach here for a number of years, so the opportunity to come back and see many of my friends here is always very special. Corinne, without question, touched upon a number of very pressing themes that are affecting all of us. And although the program is titled Project Hope, we have a lot of challenges to deal with, but I'm always hopeful with those challenges that we get through and we transition and address all of these social and other issues that are being identified. But there's no question there are economic forces at play, external, there are regulatory forces at play, and we often refer to that at Gerwin as the perfect storm of what we have to contend with. But as we've been in transition, we've been able to address that. The business that we're in has changed, and that change in the business has forced all of us to do things differently. It's one thing just to be reactive and make changes. It's another thing to try to get ahead as best we can and develop programs and services that make sense, that fit in with our mission, that address the needs of the elderly. One thing that the public doesn't realize is how challenging this business has become, certainly in long-term care. At Gerwin, I represent a very large long-term care provider. We're kind of at the, I guess I'll say, the lower end of the food chain, taking care of everyone after the hospital has done its part and done it very well. We have our own unique challenges to get people well and get them home, or to keep them safe as residents in the future. So we're dealing with tremendous challenges. What the public believes is that because of this explosion of the aging population and these dynamic changes, everyone assumes, so much of the public assumes, that we're on easy street. It must be great. We must be making a ton of money. This is great. You know, everyone's aging. It must be a great business. And what I tell folks is it's actually completely the opposite. Because in order for the system to grow and expand, we're all, like us, having to sacrifice for the greater good. So we believe we're doing the right thing, doing the work that we need to do, but it's much, much more challenging. For example, the typical 75-year-old that maybe had knee surgery or hip replacement surgery not too many years ago, I'm talking about 5 to 7 years ago, used to come to our doors, and these were the relatively easier cases for us to handle. They were better cases in terms of reimbursement. We got folks in and out relatively easy. They were easier times financially and operationally. Those cases don't come to us any longer. So as a good example, it has forced all of us to up our game and deal with more complex cases. Because if we don't have beds filled, we don't have work for our staff to do, and we're a very, very important employer. For example, we employ 1,200 staff, and we take care of 1,000 individuals every day. So if we don't have that referral stream coming to us, if we can't satisfy the hospitals, if we can't provide good metrics, we don't do a good job staying viable in this business. So we've had to make a lot of change to stay viable. I think the best example of that I can explain is about a year ago, we opened up what's called an advanced care unit. We took one unit of 6 rooms, 12 beds, and began doing a lot of what the hospital does. We're not replacing the hospital, no question, we're not. But we now monitor patients with improved technology that no matter where the resident goes, we know their vitals 24/7. So if a resident is off that unit and can go to rehab, or can go to the dining room, or anywhere else in the building that they may go, we will now know in live time what's going on with them. So in reality, if a resident has an increased respiration rate, we'll know about it. The resident may not be able to communicate it to us. It may not even be visible to us. We might notice it upon assessment when we see the patient. So knowing this in real time allows us to get ahead and do the right thing for those patients. This has been so well received by the hospitals. And so our flow of patients, our business, we're reliant on the hospitals. You know, Corinne before talked about, managed care and the impact of managed care. It's driven all of us to take a closer look at our quality and measuring our quality. We never used to measure as much. We make decisions based upon the data as best we can. But it's not easy. It's very, very challenging for us. One of the themes Corinne spoke about, social isolation. She couldn't be more correct. Folks who are at home who are not engaged, do not have the social interaction, the published data shows that they have worse outcomes. So we've addressed that. We have a medical adult daycare program. We opened up a social adult daycare program. We've done a good job of treating those with dementia. The average percentage of dementia in any nursing home in New York State is about 60%. We opened a dedicated memory care unit about 3 years ago to treat this population in a safe environment. We were turning away individuals who had need in the community because we could not safely enough take care of them. Now we're doing it, we're monitoring them well, and we're meeting community need. So that population, as it grows and expands, we began to address that. There are other areas that we would like to address and expand. Some of those are more challenging from a reimbursement standpoint, such as behavioral health, but we've been able to take steps in those directions. We opened up a short time ago an infusion center. So those folks who need IV antibiotic therapy at home can now come to Gerwin and receive those services. Our medical adult daycare program that was open on 6 days a week and not on Saturdays, we're now open on Saturdays. Why? To meet community need. So we continue to look for things that make sense to address, that provide community need, allow us to diversify, because the more diversified we are, we also believe that we can be more successful. This is all not without challenges. You know, we're dealing with some very significant, unprecedented state budget issues. I'm always hopeful we will overcome. The business may be getting harder, but I believe we will overcome. That's the challenges we face. But if you embrace it and you figure out a way, there is a way to do this and stay viable. Thank you.
Not only do we have statistics as to how the aging population is increasing geometrically, but within the aging, we have the healthcare statistics as to what's the most frequent type of problems that people face. And many of the statisticians tend to do it one-on-one. Oh, somebody has a problem with their knees, someone has respiratory problems, someone has cardiovascular. What really is not appreciated, and it's really leading to the pressure, this silver tsunami type of look-see, is the fact that any individual is probably going to have 2 or 3 problems, not just one problem. And so the degree of care needs to be compounded. And so and it's not necessarily something that's totally predictable for an individual, but it can be predictable for a population. The state, in trying to craft a mechanism, a care modality for this, came up with what's called the MLTC, Managed Long-Term Care Entity, which is really, in a sense, both a care manager and an insurance company. So somebody who's had experience with that, so Grady, who's done it, who's great experience with actual home care, and then with Empire Blue Cross Blue Shield for over the last 10 years. Give a little perspective as to what you're doing to grapple with all of this.
Sure. Thank you very much, and thank you for inviting me to participate in the panel today. Just to let everyone know, I am a registered nurse by trade, and I did get my Master's in Health Administration here at Hofstra. Yes. And it was a wonderful experience. But as was noted by all of the speakers, you know, the population is definitely aging. In New York State, we currently have about 4.3 million older adults that are 60 and older, but by 2030, that's going to rise to 5.3 million, or 25% of New York State's population. So that's 25% of the population is going to be considered aging or older. So this is why this is so important that everyone is thinking about how is this going to be addressed moving forward. I have spent primarily most of my career working in home care. And what we've talked about with all of the speakers is most people want to stay in their own home. And as they get older, the challenges to that become really remarkable. And as has been stated, some of the challenges are they don't have a caregiver to help them anymore, or they have dementia. And the numbers on dementia are just staggering. According to the NIH, people in their 70s, about 5% have dementia. But if you're lucky enough to live into your 80s, 1 in 4 have dementia. And that's a huge number. And that is going to impact moving forward, how we look at this population and how we treat this population. So I have worked in home care for many, many years. And I think that the big thing that people need to take away from living in the community and getting care in the community is that a lot of times they don't understand who pays for it. And that's a huge issue when a family member, a parent, a spouse gets sick. All of a sudden they're in the hospital and now they need to come home and they think they're going to get all this help in the home. And guess what? Medicare will pay for some limited services in the home if you have a skill, and maybe you'll get someone to help you take a bath a couple of times a week while you're getting that skilled service. But after that, you're on your own, okay? Medicaid, which is a qualifying benefit based solely on your income and your assets, most people don't qualify for. Some do, but most don't. And the benefit for someone getting Medicaid is a lot more generous, but the majority of the population is not eligible to qualify for Medicaid. I saw a statistic that talked about family caregivers or supportive caregivers, and it's estimated that family caregivers save the healthcare system over $400 billion a year because they're doing all this work to help people in the community, but they're not getting paid for it. So I was working in home care, and as Senator Hannon mentioned, the state developed a program that's called the Managed Long-Term Care Plan. Sounds interesting. What's a Managed Long-Term Care Plan? So it is a Medicaid plan. So as I said, Medicaid is really you're only eligible through your income and assets. And the Managed Long-Term Care Plan is actually supposed to help keep in the community, if that's what the client wants, someone in the home with a package of services to support them for whatever their needs are in the community. So we're what's known in the state as a partially capitated plan. So if someone needs long-term services in the home, meaning they need someone to come into their home, like an aide, to help them bathe, to provide meals for them, help them clean up their house, take them to doctor's appointments, we can provide that in the Managed Long-Term Care program. We do not pay for the acute care services like the physician, the hospital, the pharmacy. But our members primarily have Medicare primary. So they can go to whatever physician they want, they can go to the hospital, and Medicare pays for those things. We pay for the chronic care benefit. So that it's things like personal care in the home, if they want to go to an adult day health care program like Stuart has, social adult day care. We provide preventative services. We pay for things like podiatry services, dentistry, vision care, hearing aids. We also pay for things like environmental modifications. And what's an environmental modification? That could be something as simple as looking at a bathroom and saying you need a handheld shower and a grab bar in the bathroom so that you're safe to take that bath or that shower. It could be as extensive as putting in a stair glide in a home, a ramp so that if you're in a wheelchair, you can get out of your home that has those steps, in the Levittown house that nobody thought about that was inaccessible. So the premise of the Managed Long-Term Care Plan, it is an insurance product, and we are paid what's known as a per member per month. So we get the same amount of money for whatever member is enrolled into our plan. But there's a wide variation in our population and the kind of services that they need. So the premise of the state is that you'll have some population that has lower needs versus population that has higher needs. And I can tell you that we have folks in the home that have what's called a live-in aid, where they actually live in with the member. We have folks in the home that actually have 2 aides that work 12-hour shifts that are awake 24 hours a day, because the level of need for these clients is so intense that they may need their bed bound and they may need to be turned and positioned every 2 hours to prevent a bed sore. We also can provide an LPN in the home if you require that level of care. But as Stuart mentioned, the challenge is financial. The state is seeing an explosion in Medicaid payments, and so they are looking to try and rein in their budget, but yet the population who requires long-term care in New York is mandated to join a managed long-term care plan. If you need Medicaid long-term services, you can't get that through fee-for-service Medicaid. You do have to join a managed long-term care plan, and there are plans all throughout the state of New York for that purpose. So it is actually interesting times right now, but I will tell you that each one of our members does have a dedicated nurse care manager. We do assessments of our members in the home. We do provide the plan of care that's required for that member based on where they are in the continuum of care. Our care managers do telephonic care management of the members, and we encourage them to use all of those preventative benefits because it's important. As Dr. Lieberman stated, if people can't see, they have a higher percentage chance of falling. If they can't hear, it makes them more socially isolated. You know, even dentistry, they go, well, my teeth are, then it doesn't matter. But if they can't eat well, then they also have a higher percentage of possibility of having disease and ending up in an emergency room. As an MLTC, we're also, talk about metrics and quality and measurements. We have to prove that we're preventing people from going into the hospital, and there are some measures around potentially avoidable hospitalizations. And so we are always instructing our members to call us early, call us first. We want to intervene quickly, and we encourage and we train our the aides that are in the home. They're not our aides through the plan. We contract with what's known as licensed agencies who provide the aids to our members, and we work with those licensed agencies to make sure that they're training the aides to call us. They are the eyes and ears that we need to see what's happening with a member. And it can be, the aides, don't have to have an RN degree or anything like that, but they know when something's wrong with the patient they're taking care of. And it can be as simple as they get to the house that day and they can't get that client's shoes on. That's showing that, wait a minute, their feet are swollen. What's going on? Maybe there can be a change in their medication. So if you call us early, we can get in touch with the physician, maybe change those medications and prevent that hospital stay. Because anecdotally, we see once these clients who have multiple comorbidities, and our population average age is about 80, we have about 7,000 members that we serve on a daily basis, 70% women, 30% men. Sorry, guys, there's more women that live longer than the men. But if we can keep them out of the hospital, it also helps us in the utilization of services, because once they are hospitalized, it is so much harder for them to recoup and to get back to whatever their baseline was before. The other big issue moving forward is that there is going to be a huge need for these aides taking care of people in the home. They're just, as the population has more and more need, there's going to be more and more need for aides. And it's estimated that over the next 10 years, New York State is going to need 190,000 more folks who provide direct and indirect care to members. We believe that there's going to be a need for over 52% of the number of aides that are out there now has to grow in order to meet the population needs moving forward. So there's a lot happening, but I would say that, we try to keep people as healthy and as functional and vibrant in their homes and communities, but it is a challenge. And it's a challenge for the caregivers because we are there to support the caregivers, and it is a challenge, especially when you have a client in the home with dementia. It can be very exhausting and draining. And so we also have social workers that work with the caregivers, the family caregivers, to get them involved with supports, because if they burn out, then the member is not going to be able to stay in the community. So it's really a very holistic approach that we use to try and use, services that are going to keep people as healthy and as functional in their home for as long as possible. So thank you.
Right. I kind of want to ask each of you a question, because we know that the numbers of aging is increasing, and most people have said, well, it's the baby boomers, and once we get past the baby boomers, we won't have this challenge. But if you look at the demographics, once we get past the baby boomers, it doesn't diminish that much. And in fact, way down the road, the millennials are already more numerous than the baby boomers. So we have a huge structural problem, and it's probably not only the United States, but all of the Western nations. So given what you've said and you've heard, I just have one simple question. Besides volunteer banking, which I'd like to be a part of, what's the one thing you'd change? Stuart, you have this complicated system of integrated health delivery. What's the one thing that you would change? And by the way, more money is not an answer.
I think the shift that we've been underway to provide more outpatient services, other services, meeting those other needs, getting away from institutional care is probably the way we have to go. We know there's tremendous building going on in terms of assisted livings, independent housing, and there's need. I'm almost afraid that once we get past the baby boomer population, what are we going to do with all of this construction, all of this housing? What is that going to mean? Are we going to have to, diminish that infrastructure? So I believe that one thing I could change is I would continue that shift. But we are in the business of long-term care, and we want to stay viable. So it's that challenge of continuing to do what we do. So maybe it's changing the nursing homes to be more like other types of housing. That might be an answer.
Dr. Liebman.
There are so many things I would change. However, I guess just if I'm going to focus on healthcare, I would say the education process around healthcare providers understanding how to care for an aging population. We have done not such a great job of teaching nurses, social workers, physicians, nurse practitioners, PAs about how to care for an older adult and how to look at them through the eyes of a healthcare provider. I think we have done a great job of teaching them about their specialty or about a specific thing that they need to learn about, but they haven't really been understanding how all of these things are impacting the care that they're providing.
Where would you do that teaching?
Probably when they first start in their schools. In medical schools, there's a 1-week block of geriatrics, if that. They may get a week in palliative care. PAs don't get any of this training. Nurse practitioners may get a few weeks at most, unless you do a specific geriatric certification. So I think that education is in the basics of medical school and nursing schools is where we really need to be more focused on this population, if I'm going to just say about healthcare.
Professor.
Can I say two things?
You can say,
So,
there are no rules.
so one thing is, I mean, I would like us to continue moving forward with reimbursement reform. I really do believe, and my students who are here have heard it, and if you haven't, I'll say it again. Form does follow financing, and so once we change how we pay for things, we begin to see a different kind of product. So I'm really hoping that as we continue to move, and get more advanced and thinking about integrating social and healthcare services, we start to pay to make that easier to do. I think it's very difficult to do, presently, and that's some of those barriers. And then the second thing is, and I talked about it in terms of, building up communities and this time banking, but it really is the caregiver intervention. I really think that we need to think about new models for paying informal caregivers, for finding ways to enable adult children who are caring for aging parents and for their own children to have more supportive workplaces. I think we need to rethink how we address caregiving and recognize that it's universal, and for those who don't have caregivers to find ways to put in supports.
One of the things that happened with the state was a program called Consumer-Directed Care, and it started out as very informal. You have your mother, sister, brother, father taking care of you at the home. Can we give some money to support that? We can pay for it. Well, that expanded from a little acorn to a huge tree in an order of about 6 years, to the extent that people were and are advertising on the subway, like, get paid to take care of somebody in your family. Well, that's caused a huge budget blowout where reforming of that is absolutely on the order of everybody's business, even not in a punitive way, but to say, wait a minute, you can't get this immediately. There's no look-back period as there is to get nursing home care. In other words, you can wait about a month, I think, or 5 days, and you can immediately be qualified for it. Anybody can do it. So there needs to be some shape, because the unrealized demand for the care in the home is there. And to the extent we don't think it out, and it's not just, by the way, for the aging, though that would be the primary beneficiary, it's going to be for anybody who has a disability of one way or another. In fact, I think the origin of the program was for people who were mentally competent but physically disabled, and so they could do their own directing, the self-directed, consumer-directed. So it's a question of, when we do make changes, do it thoughtfully. Stuart.
Having thought more about your question, one thing, a little more time, but one very important thing I don't want to overlook as a long-term care provider. One thing we have to change is there has been a dramatic shift in the past several years in New York, other states as well, but mostly in New York, from the not-for-profit sector to the for-profit sector. It used to be that about half of the homes in New York State were nonprofits governed by a board of directors like Gerwin. And we have seen such a shift to the for-profits that we now represent maybe just 25% of the industry, and that's a problem. We know, just based on the published data, that we put more into our staffing, more into our care design, produce better outcomes, have overall better star ratings. And what we're seeing is, we really are seeing a deterioration to some degree in what's happening, certainly in long-term care. And we have to see that shift change. I am very vocal, as many of my colleagues and some of you are here today in the not-for-profit world, in really pushing the state and educating how important and vital we are to promoting good care as a nonprofit. And that shift really is a major issue that we're all dealing with. I happen to sit on 2 boards that represent all of the nonprofits in New York State, the Greater New York Hospital Association, and up in Albany, what's known as Leading Age. And this is something we've been grappling with around the boardroom table very significantly. What are we going to do to push the mission of the not-for-profits? Because we know certain things we put more emphasis on as compared to the for-profits. Many of the for-profits are doing very good things, no question, but again, if you look at the data, it will tell a very different picture. So we've got to figure out a way to kind of stop this change really before it's too late and we see a lot of bad things happen in long-term care, which, by the way, those of you around long enough saw in the 1970s when a lot of very unfortunate things were happening in this industry.
One of the things that seems to run through this shift to the for-profit, it's in nursing homes alone, not in hospitals, because they're all the hospitals in the state are not-for-profit. But one of the themes that's underlying this, each of your responses seems to be our workforce. Whether or not we have a sufficient number of people coming into healthcare, whether or not they're trained in a wide enough range of the discipline, and whether or not maybe we've fractionalized it too much. Continuing with the acronyms, the LPNs and the NPs and the PAs and the advanced, et cetera. Is there any way of addressing, Marianne?
Well, I just wanted to, to your question earlier, what would I change?
Oh, yes.
One of the things that I think it would be so important is if everybody started to think about how they picture their later life and what they would like. Because I think so many times, you can't plan for everything, but you can at least plan on, we have a very difficult time with a very older population with multiple comorbidities that nobody's ever had a discussion, the family or the members, about what is their wishes. And a crisis happens, and everybody's in a panic. And sometimes the right decision maybe for the member is not made. And I'm sure Dr. Weidman can speak to that because, sometimes folks are at a point in their disease process where a physician will say, well, we could do this. And is that really the right thing for that member, which may extend their life, but what's the quality? And I think that, so many people are afraid to talk about end-of-life issues or complete an advance directive or a living will. And I think that if it became more of a conversation, it would not be as scary to the whole population as a whole. And I think that families really have to have those kind of conversations before they're in the emergency room and they're making that choice of, does somebody go on a ventilator or not go on a ventilator? And it is a very, it's very unnerving. And unfortunately, you don't want to think in terms of dollars and cents, but it's very expensive to the whole overall health system. When you were talking about all the different acronyms, and I just wanted to comment on consumer directed because that is a benefit to our program, and we have seen a larger number of folks coming into it. And to your point, it's a fabulous program, and it was started back in the early 80s, particularly for young disabled populations who did not want to be tied to a particular schedule. They maybe just needed someone in the morning to help them get ready to go out and somebody in the evening to help them. And it worked really well. And the state is the one who kind of opened it up to any willing participant to open up what's known as a fiscal intermediary to basically be the payroll and provider of the PA or the personal assistant that the client wants. And it's great if the client can direct their own care, but what it's become is it has allowed, if you have someone who's demented, that you could have a representative who's now overseeing the PA, and sometimes it's a situation where a family member is just unemployed. And so they decide that's the person that they want to be their aide. They may not be the right person, like they don't necessarily have to be skilled, but it is not necessarily in the best interest of the client. And every case is different, and it does work well. I can give one example where we had a situation because a personal assistant under this program can provide any service to a member that a member could do for themselves. And so it works well when you have someone that might need an injection or tube feedings that a traditional licensed agency aide is not allowed to do under their scope of practice. So it does work well in certain situations where a family member says, hey, I want to learn how to do this. I don't want a stranger coming into my house, and they can do it very effectively. So there's a balance on it. It works well in some cases, and it doesn't work well in others. So.
All right. I'm sure no one has any questions. But we'll take the questions. I've stolen the microphone that's due to go to the center there, and give you that back. And we'll take some questions. And
I know I introduced myself as the assistant dean before, but I could be the mobile microphone too.
Okay. I noticed one thing nobody has mentioned on the stage is politics and the VA, Veterans Administration. Okay? In the case of politics, a curse word in this country is socialized medicine. Okay? Now, I retired in 10 years ago.
okay, but you got to ask a question.
Okay, here's my question.
As a moderator, I get to say,
Okay. All we have to do, as far as socialized medicine, is look to the European countries who have this is the worst country in the world to retire at, okay? Okay. The question is, why don't we just copycat the European countries? Now, I have a bit of socialism because 3 years ago I joined the VA. I was in the Army in the 60s. The VA is saving me thousands of dollars in prescriptions alone. What's the reason? The VA negotiates with the drug companies. The U.S. government doesn't negotiate.
so
Are we looking into European countries to copycat then? That's my question, okay?
very legitimate question.
The question is...
How we change the delivery system. As the professor talked about, how we change the reimbursement for the delivery system. Literally, though, the thought was, let's just start addressing, and you raise a very good point to go down the road, start addressing where we are and what our problem is, and then the thought will be, we have more forums to have on aging. So that's what we want to do. But since directly to your question, I'd ask the professor to respond because it's a good question.
It is. It's an excellent question, and we talk about it a lot in our classes, and we mull over it, and we recognize that there are lots of socialized systems that we have. Public education, even Medicare, is run by the government, and it's a beloved program, and it works really well. But you're right. I mean, it has become a difficult topic of conversation. But it's not so easy as, copying another system. We can learn from other systems. There is no panacea. There's no perfect system out there. A lot of the systems, European systems that have universal coverage, they have lots of different kind of challenges. There are public and private partnerships in every country now where there are private systems and people are buying out. So it's not so black and white or clear cut. But I think that your question is an important one. And I think we're starting, actually, as a country, thanks to Bernie and others, to have, a conversation without, as being as prickly about that term. So do I think that means that, we're quickly going to move in that direction? No, but I would be willing to say that, we will see in the next few years a public option where we will be able to see people buying into a Medicare-like program, even if they're not 65. I think we have a way to go, but I think we're moving closer to a system like that.
I actually think we've been moving in that direction since the 1980s, and I think just the natural forces that are occurring, we're going to be there. For better or worse, we'll be there. I mean, we're now hearing the term very similar to what you said, Medicare for all. Mm-hmm. There's positives and negatives with that, but I think the natural forces were going in that direction. We'll see how that plays out for all of us.
And one other point.
Dr. Lieberman, did you?
I mean, the only thing I would say to that is, I think that there's a lot of controversy. I think that in other countries, there are age limits on things like dialysis, surgical interventions, interventional catheterizations. I'm not so sure that an 80-year-old who's healthy and well here would take lovingly to, well, I'm sorry, our insurance isn't covering it because you passed the 80 point. So yes, I agree there should be some reform in the sense of when do we stop at a certain point in their lifespan, not saying their age, but their health problems, but who makes those decisions, and does that become a power? And so I think that it is difficult. There's no right or wrong answer. I struggle with this too, believe me, on a daily basis. But I think that there's a lot of movement in that direction, but we haven't gotten there yet because of reasons like that. And it's thoughtful. You have to be thoughtful.
I also have to say one thing. He's talking about socialized medicine being some type of bad word. I look at the other systems that in the other countries, we actually are more socialized than they are. We have more regulations, we have more governmental intervention than they do. And so it is a political fight that really has, I don't know, no real relevance towards improving our healthcare system where we are. And that's keeping politics out of it has always been my goal. Marianne, did you want to say? We'll go to the next question.
Okay, go to the next question. It's okay.
Thank you. I guess this question is for Dr. Lieberman. I operate a senior living company, and I'm also a member of a national organization, senior living organization. One of the incentives or I should say one of the leading goals of the organization is to decrease the use of off-label antipsychotics. What is your take, and really it's really for everybody on the board, I guess, what is your take on this? And I'm talking as they apply to dementia, Alzheimer's, et cetera. Is it overkill that we're saying not to use these medications? Is it really that damning to be utilizing these meds? And given the fact that memory care communities are sprouting up all over the nation, dementia, as we spoke about, 1 in 4 will have, et cetera, 1 in 3, depending who's doing the study. But what's your take on that?
So I think that the regulations around antipsychotics was there for reasons. There were patients who, at higher doses we found had strokes, who had, cardiac issues, and so they put what we called black box warnings around them. The reality of it is that the patients that we're utilizing these medications on are patients with really advanced memory loss and agitation. And the reality of it is that the patient can harm themselves or others more so than the risk of them having a stroke or having some cardiac event. And so the pendulum has sort of swung back in the sense of we are, healthcare providers are utilizing these medications because the population is growing and they are more memory loss and more agitation. It's causing difficulty for care providers, for them to stay in their home, for them to stay in nursing homes or rehab centers. And so we are utilizing them in smaller doses with knowledge around that and saying, what are the risks, benefits? And that goes back to having conversations with their care providers on what's most important to them. Is it most important to them that they're just calm and comfortable, for their whatever quality of life they have, in contrast to the fact that they have something happen suddenly, like a stroke or death. So those conversations are really important to be had when prescribing these medications, and documenting it and making sure that everyone knows, especially in nursing homes and rehab centers where they're being oversought by, the Department of Health, who's going to say you're just giving medications to make them sleep, and keeping them quiet so your staff isn't being affected. That's not the reality of it. We're really doing this for the safety of the patient and the safety of the care providers. So I thank the question, because I think we went one way where we said stop taking any medication, and now we're swinging the pendulum back because of this growing population and saying we need to utilize these, we need to be thoughtful about it, and we need to understand why and document them.
And in some cases, they've been like miracle drugs because without the treatment, people were really lost.
Unfortunately, we do not have a pill that's going to cure
No.
Alzheimer's dementia. We do have medications that will provide, patients to be more calm and more able to live in society with medications like antipsychotics. So we have to utilize them in a correct way.
And can I just add to that, because working in the home care world, we find a lot of times folks with advanced dementia, they don't sleep all night, and they're very combative, and they're up, and they're yelling, and we'll speak to primary care providers to say, can we give them something so that they'll sleep? And they'll go, no, we can't give them anything. And it's like, but it doesn't make sense to have somebody up and agitated 24 hours a day. It's not good for their health, and it certainly impacts someone being able to care for them in the home. So there is definitely still, I think, some bias by community primary care physicians who are very reluctant to prescribe any sort of that type of medication, even when it probably could help the member stay more safely in the community.
Just so everyone knows, I'm seeing a lot of hands for next questions. I've identified a few already, but I will do my best to get around to all of you.
Thank you. First of all, I want to thank you for a very interesting discussion. My wife and I have experience with a lot of the things you talked about. My wife's husband was in a nursing home for 5 years, her first husband. My first wife was in a nursing home for 14 years. However, I have a question for all of you. Do you know about the lifelong learning program here at Hofstra? It's been here for more than 40 years and is under continuing education and is a very successful program. It's called PEER, for Personal Enrichment in Retirement. We have members in their 50s. The oldest is 100.
Wow.
By the way, he drives, he plays bridge. It's incredible. It keeps us all young. I'm 87 years old, and I got to tell you, it has made a tremendous difference in my life. And one of the beautiful things about this program at Hofstra is we do our own presentations. I've been in other programs at Johns Hopkins and at Florida Atlantic University, but they're quite different from Hofstra. Hofstra is really terrific.
This is beginning to sound like a commercial.
Okay, great. Good, I'm trying to. But the other thing, are you aware of the PEER program?
Yes.
Here at Hofstra, and what it does for people like my wife and me?
Yes, and many of your members came to our Aging Cafe last year. I hope that you'll come again this year during National Public Health Week, and we do the School of Health Professions and Human Services to try to reach out and invite PEER and hear about the events that you're doing as well. So yes, and I'm so glad it's been a great experience for you.
That young lady right next to your right, you had your hand up for second, right there.
Yes. I have one more person ahead.
Okay.
First of all, I want to thank you all for sitting down this morning. This is sort of piggybacking off of what Dr. Lieberman was talking about earlier in terms of health literacy. About 12% of Americans are considered proficient, according to the Department of Health and Human Services, as health literate people. More than 77 million Americans are considered basic or below basic in terms of health literacy. I know, as a fact, an example within my own life is that my grandfather had problems with his aortic valve, but the doctors didn't tell him that. They told him he had a leaky heart, and so. But if that was me, they would tell me that I would have an aortic valve and possibly need a transplant or treatment as such. And in terms of that education that you were talking about, in terms of change, how do you see healthcare programs and maybe just universities in general taking steps into making sure that students and this aging silver tsunami are aware and literate about their health, so that way something as serious as an aortic valve doesn't get passed along as just a leaky heart?
So, I mean, I'll answer that in the sense that, you know, work at the medical school here at Hofstra. It's affiliated with our health system, and we actually have done a lot of work around how to communicate. So they have a communication course from day one all the way through. They are out in the community with the physicians from day one as well. And I think it's all about how you communicate, listening to what the patient understands and how to feed that back to them in a way that's at terms with their level of education. And so I think that's a new sort of shift in the way that healthcare has been, in that we are trying to communicate the issues with our patients and their caregivers, our family, in a more concise way and in a more meaningful way, instead of just, this is your, you know, you have high blood pressure, diabetes, blah, blah, what does that mean? You know, most in the past, nobody really understood what that meant, and we just accepted it. So now we're trying to be more about communication. I think that's just in healthcare in general. I think we need to be better communicators, how to have conversations. We've actually, the health system has created something called a Goals of Care conversation course, where any provider can go and learn how to actually speak to a patient and their family about what is happening and what they understand and what are their goals and their discussion around that. And so we've been very successful under some of our leadership that's actually sitting here, thank you. So it's really wonderful to think about how do we communicate better. I think it's just basis.
Stuart.
We created a dedicated position of a discharge nurse with the goal to help educate folks better, that when they were leaving our facility and going home, that someone was going to hold their hand, educate them, make sure all the services are lined up, make sure they knew what to do in terms of medication management, because what happens is someone's life has typically changed when they come into our doors. And when it's time for them to go home, the family is not equipped. Right? They're not knowledgeable, they're anxious, they're dealing with finances, many issues, taking charge of the household they didn't have to do before. So we've invested in helping to educate them better so they can go home safely, that they don't hopefully just bounce back to us. And I think it all goes back to the original discussion we had before about education. We can do a lot more with. So your question was well taken.
Now this young lady has her hand up.
Yes, hello. I don't want to replicate what my colleague from Pier at the front of the auditorium said, but to Tara, with your 4M proposal, mental stimulation could be the fifth one, and Pier, which is right here at Hofstra and part of the continuing ed department, does people that have come to Pier in acute states of depression have said that Pier has virtually saved their life. In addition, we have at least 15 or 20 members who come with caregivers, who come with crutches, who come in wheelchairs for the intellectual stimulation that we provide at Pier. And we've been part of Hofstra University. We meet right here on the campus. I apologize that I'm not framing this as a question, but sitting next to me is a gentleman who has belonged to Pier for 45 years.
Wow.
We have 95-year-old members who, without a single note in front of them, can stand up and speak for an hour and a half. And that's what mental stimulation is doing. So there are peer brochures at the back. Yes, this is a pitch, but it's to everyone's benefit.
I would agree with you in the sense that the mind is not only about the memory loss, it's about keeping your mind active. And so that is an example of how we really want to offer opportunities in the community wherever you live, including something like Pier. I mean, I know that, you know, their day programs have a lot of mental stimulation. I'm sure that, like, just even the volunteer program that you're talking about in Glen Cove, that volunteer program is an amazing mental stimulation, engaging your mind. That's how you stop memory loss. That's the reality of it. There's really no pill that's going to fix this. It's the only thing we really know at this point, just engaging your mind as best as you possibly can. And so, you know, there are local JCCs and Ys and libraries that all provide very similar things. And so whenever you know a family member or loved one, suggest it. I think it's a great opportunity. I know it works for my parents. My very happy with their book club and, I don't know, current events every week. I forget. They love it.
Hi. So you guys spoke a lot about protocol and regulations are in place by the government for a lot of these programs. Specifically for the program where the family members are getting compensated to care for these caregivers, how do you account for fraud?
Oh, yeah. I'll take that question. It is difficult. The family members do, okay, so what happens is whoever is going to be the designated caregivers have to sign up what's known as a fiscal intermediary, which is primarily the payroll provider. So as a plan, we set up what the plan of care is for the member and how many hours a week of service that they're supposed to get. These caregivers are clocking in and clocking out. So there is a mechanism. Now, can we prove exactly where they are at every minute? But they do have to clock in and clock out in order to get payment. There is no current regulation where there has to be a like a check-in or somebody to go and see if they're actually there at the time they say they are. But I can tell you from my organization, when the care manager does their telephonic calls, they always try and call when that caregiver is supposed to be there and talk to them so that we can kind of do a check on are they actually providing the care that the member should be getting. Yeah. Yeah.
I know,
Get your
forgive the
steps- you
delay.
get your steps today.
Kemp's having me work out today.
Hi, good morning. Thank you very much for the wonderful dialogue. So my question to the panel is, we've talked a lot about what matters most, or otherwise sometimes called having goals of care conversations. We know they're not happening, but they're not happening as often as they should. What can we do, either governmentally, and I hate to say that because it's just more regulations, socially or medically, to increase these having these conversations? They're challenging, they're time-consuming, and they should be across the continuum of care.
I don't know what happened to that.
I remember a few years ago, there was a mandate where physicians were supposed to have these conversations, and it got told to be death panels. That was kind of the term that I remember people were using. And it really was, Medicare would reimburse physicians to actually have these conversations, but it became very twisted around in the whole purpose of it. Oh, it's only going to be to save money. But it really isn't, because I think everyone needs to have those type of conversations. And as I said, you can't plan for every eventuality, but you can kind of have a framework of where you think your life is, you know, where you want to be, where you think you want to be, and at least be able to communicate with other family members or even, you know, your close, you know, support structure. I think, you know, because it does involve a lot around medical care, I think it really does fall back to the community physicians to really start those conversations when people are well. You know, not when it's a crisis, when people are well. And I think that if that becomes more of the norm, I think a lot more of the stigma around those conversations would go away.
In addition, even elder law, elder care planning, if these things happen earlier on, I know
Right.
these are things that people don't necessarily like to go and shop for, but if we do those things earlier on, it'd be much better than when someone's really under duress with great anxiety.
Right.
The only thing that I'll just add to it is that I think also we need the community to feel more empowered to have those conversations. And so I agree that it has to happen kind of before there's a crisis. So there have been, you know, programs and initiatives that are trying to get people more comfortable with having those conversations. Recently, Northwell and the School of Law and the Public Health Program and medical school were working together on an initiative that's, the acronym is CHAT. I can't, maybe Dr. Chowdhury remembers what it stands for, but it's about, you know, partnering with religious organizations in the community to, kind of normalize and also make the conversations culturally appropriate so that people get comfortable talking about advanced care planning, talking about goals of care, and not having it something that, is so scary and only at the time of crisis. So I think that we have to do better, from the healthcare workforce perspective, but I think we also, kind of need to build it up organically from communities to feel
The only
comfortable with it.
caveat, and I think that the chat program has been an amazing, successful thing in this community, going to the community and going to their religious places, because the reality of it is, if you look at a primary care physician's day, they have 15 minutes per patient, and then if it's a new patient, they get a half an hour. And so, it's really not a lot of time to have this, and they're not really reimbursed very well, and they're not educated on how to have the conversation or how to document it and bill for it. So that's primarily why it's not happening in the community. So I don't blame them. It's just not, we haven't set up regulations through Medicare, through insurance companies to really reimburse people or incentivize them to actually do this work. And so what I would probably propose is that we could change the way we incentivize our physicians, maybe give them a financial reimbursement or certification around having that taken a course, or giving them once a year a half an hour just for what matters most to a patient over the age of 65, something along those lines, because otherwise if we don't do things like that, it's really unfortunately not going to change. And that's kind of why the person who kind of has those conversations the first time, unfortunately, is our ER doctors. And they realize it and are really scared about it.
Dr. Kyriakou referenced Dr. Chaudhry, who's actually with us and has a follow-up comment.
So, first of all, a great panel. Thank you so much for addressing such an important topic. However, it's interesting how the conversations are either, not in this panel, but generally in healthcare arena, the conversations are either about health or about crisis care. Mm-hmm. So the chat program, which stands for Conversations, Health, and Treatment, basically encourages communities as well, because if these kind of conversations are initiated in the communities, then it will go to the healthcare providers as well, and people will ask those questions to the healthcare providers. So it's a very successful program, and I would encourage communities to come forward and have and organize these events for the communities, whether they are in the places of worships or the libraries or whatever community forums there are available for
Can I suggest that you meet with Pierre?
Yes. I was thinking the same thing.
That. Seems like they would be a great people to see one day.
Just volunteered myself.
Yeah, there you go. If they'll have you.
Hi. Thank you again very much for being here today. Very important topics. Marianne, this is, I think, more so to you regarding the home care programs. I understand people, Medicare, Medicaid, they get an incentive care. Affluent people can have private care and fortunately can afford that.
Right.
But what are they doing to look at lower income to middle income people who need this helping hand, huge part of our population, and they don't get these supplemental services? And are there any advantage plans or your plan that's specifically looking to provide like some type of supplemental help to these clients?
Right. So I know that just in the past year, there's traditional Medicare, which if you're 65 or disabled and you've worked and you've paid into the system, that you're eligible to get Medicare. There's also what's known as Medicare Advantage plans that are through health insurance companies. And just in, I think it was 2019, Medicare allowed that some of those Medicare Advantage plans could add some supplemental benefits. They're minimal, though. There are plans that will give some small hours of personal care. There are plans that will add on transportation, extra transportation benefits, and some that will do things like heavy-duty cleaning in the house. But the consumer has to pick which one of those things they want to use. But the way the system is set up right now, there is a big gap between who, qualifies for Medicare versus who qualifies for Medicaid. And I just say this as there's a lot of ways that people do qualify for Medicaid, good, bad, or indifferent, but you can qualify for Medicaid if you do some planning ahead of time. But there is a big gap for the people in between. And Medicare really only covers like that kind of gap between a hospital stay or a nursing home stay where you need some short-term skilled services in the home, but they don't pay for those long-term, ongoing type of supports that a lot of our older population does need. Yeah.
And to address your point about people who are less wealthy, the MLTC is a Medicaid program, so that per se it's people with less money are in that.
Right.
And the framework of the MLTC is not just, it's a way to get away from fee for service and into more of a managed care program. And in fact, MLTCs have an obligation to pick the best thing for the patient. Now, there's obviously a fiscal restraint on that, but that's their obligation. And so in theory, it's what you're asking for is there. Whether or not because of the rapid increase in the population, it's now over 230,000 people in the MLTC throughout the state, where 10 years ago it was about 12,000. So it's a pretty rapid increase. But whether or not that increase can accommodate that care is an open question. By the way, New York, in terms of its insurance for people, whether or not it's a complete insurance or not, has now 95% of the population have health insurance, which is the highest it's ever been. One would hope we could, A, keep it there and then improve what they have to do, because deductibles can erode the benefit of that insurance.
Good morning, everyone. So I have a pretty similar question. This year, HIMSS proposed a question about addressing aging in rural America. So my question to all of you is, how would some of your policies change either clinically or from a business viability standpoint for rural communities where everything may be even more fragmented than the suburban or urban areas in New York?
I'm happy to take that one. One issue that is pressing right now that we are beginning to hear a lot more about in legislation has to do with staffing ratios. That's something for those of us who are providers are very concerned about for many reasons, that we don't view that as a very positive thing, especially in rural communities who just have such difficulties, especially with the labor shortage. I know Marianne commented on that in terms of nursing assistants. If we have ratios in effect where we can't even find people, or there are no agencies available to provide the labor, we're just going to make our problems worse. So rural America has a very, very different challenge. I mean, we have the challenge also to attract and retain labor, but it's much harder in the rural community.
Right. And I was going to add also that I think we have to really leverage technology, because there's a lot of, telehealth availability, also video telehealth, so that providers could, interact with folks via video chat, video visits. And I can tell you, just with the MLTCs that I'm aware of in New York State, upstate is very rural. Everybody thinks New York downstate, but upstate's very rural. They have a very high percentage of consumer-directed care up there because there is no workforce to provide that hands-on care. So they have a very high percentage of folks that have either family or social supports that provide that care to them under consumer-directed.
I have a question about the structure, if you could tell us
Speak up.
The structure and the networks that might be there for training and raising the profile of home health care providers, assistants, people who have no formal education
Right.
or in the medical field, in the health services field. What kind of initiatives might be available to raise the bar for those people, to make it more attractive to come in to the industry?
Right. Well, several things. New York State, over the last couple of years, has raised the minimum wage. That was one of the things that they've done to get up to the minimum wage, which is $15 downstate New York, to raise the pay to aides that provide that care in the home. The state has also set up programs called WIOs, they're workforce investment organizations, and that is funding that the state has given some targeted organizations around the state to provide training to folks who want to go into that line of work. They can get their training because they need to get a certificate, a certain number of hours of training, and that's available to them for free. The WIOs also provide ongoing continuing education for different topics, like working with a dementia client, identifying decompensation of a member in the home, how to prevent falls, what to look for in the home. So there is some training out there now. So it is available for folks who are interested in going into that line of work. But I will tell you that sometimes the challenge is it's not easy work. It's not easy work to be in a home with someone who has a lot of chronic illness, or maybe they're a little cranky, or maybe they have dementia, because minimum wage also goes across your fast food organizations, your retail, and so it's trying to get the right people with the right, skill set to want to go in, and it's really people who want to help. And that really is trying to reach out to kids in school and give them that ability to kind of hear what some of these professions are,
I mean, I have actually seen some health going into schools, getting them to do this work so that they're going on a trajectory of either becoming a nurse,
right,
or becoming a physician, or becoming a nurse practitioner. So there's a lot of it. I think there are opportunities to incentivize that you do this work, you're going to be a part of it. It would be a part of your training for the future of other, and it will teach them, like, this is happening in the community. This is what you have to look at when you're taking care of a provider. And we do that with our medical students, that they go out and they do ambulance work. Maybe we expand something to something along those lines. Is also an opportunity to expand the workforce and teach and incentivize.
I think also more providers are doing this, more than we even realize. I know most of my colleagues, we do it as well through our home care agency. We're doing workforce training to help us with our own recruitment, education of folks to work out in the community. So I think it's more prevalent than folks realize. Never enough, but it's out there more than we realize.
Two more questions.
I understand that there had been some legislation, or perhaps it was passed or not, in regards to the home health aides expansion of of their services provided to clients. Okay, and specifically, it was my understanding that they were going to be trained to be able to perform a little bit higher level service, such as ostomy care, or even putting a prescription cream on a client's body. Okay, even those types of things, and it appears that this has been dragging. I don't know what is happening. If maybe one of you can address that issue.
Yeah, I am aware of that. There was legislation passed for like an advanced aid.
Let me tell you about this.
Yeah, go ahead. Go ahead, he knows.
It's called Advanced Home Health Aid.
Yeah.
I called them AHAs.
That's right.
And it was passed a couple of years ago. I was there. And looking at what was happening with it this past summer, they just issued the regulations. It took the state 2 years to issue the regulations. It does do, these individuals will do a little bit more than just a aid, but it was negotiated, and it's kind of a lesson for what we have to do in the future. It was negotiated with the nurses, who were jealous of their prerogatives. Now, they're not alone. Every other medical professional, whether it's a lab certified person or a physician, is jealous of their prerogatives. So when you try to change the lines as to who can do what, you have a little bit of a road ahead of you. But it can be done, and it was done there, and so there's more to be done. So right now, they're just starting to implement it. Dragging their feet, you're absolutely correct. Last one.
I'm honored. So what we've been having a lot of conversation about, when it comes to elder care, when they either go in the hospital or trying to be into the community. But one thing that I don't think was really emphasized, and I might have missed it, was the idea of a patient who really comes in and has nobody. And we call those, and Dr. Lieberman and I have worked on cases like this together in the hospital, is how do we understand that person's narrative and their story and what matters most to them when they don't have a next of kin, when they don't have a guardian, when they don't have a healthcare proxy, and even when we have access to their nursing home, therapist, or physicians, and they have no idea what this patient would want in a given situation. So when it comes to the unbefriended patient, who more often than not is elderly, how do we address those kinds of situations? And the reason why I'm asking is because I'm looking for strategies for when I have to deal with this in the hospital.
I do have some sense. There are a couple of guardianships in statute in New York. There's one for tend to be younger people. There's one that tends to be for the older. The one for the older statute is a terrific law. Unfortunately, it has no money behind it. Last presented with that as a challenge, I didn't know how to change the statute because it was pretty good, so I got a grant for people in Nassau County, got a grant for people in Suffolk to try to implement it, find lawyers to be paid. It doesn't have to be a lawyer. To befriend the unfriendly. Where we go in the future, we will continue to have that problem, as many of the decision-making problems that have been outlined today exist. The advanced directives. How do you deal with that? And is an advanced directive as good as it ought to be? Those are some of the types of things. So we're not there. We're on the cutting edge, and. With that, I'm going to say that that's the end of the question. But it's also your applause is for these terrific speakers and panelists. They're just great. I would hope that you would give us some more thoughts as to where we go and what we ought to do. This has been an attempt, and it's, I think, hugely successful, at a dialogue about health policy that is absent some of the emotional things that sometimes enter into it. It's a dialogue that I think is moving forward and has done exactly what I thought we needed to do, is set some parameters about where we ought to go for treating the aging in New York State and especially Nassau County. So thank you very much. Thank you for Hofstra. Appreciate it.
Thank you, everyone. On your way out,